Everyone, thank you for joining us on this episode of the podcast. Shaun, Brewster and Bodine, Ledden. Bo, today we're going to ask the question, do you know your neuro? And for two reasons. Firstly, one, it's fun to say, do you know your neuro without tripping over your tongue? And two, it's such an important question for every clinician out there. And if you're not asking yourself this question, you're potentially not doing your best work clinically, I think.
Yeah, well, if you don't know what to look for, then you miss it because you don't know that it's there. And, when we look at the nervous system and perception and sensation, integration of all of that sort of stuff, that's where we have a pain experience. But, we've got to understand, is that nervous system functioning appropriately? Is it, is there positive signs or negative signs or, heightened levels of sensitivity or diminished or decreased levels of sensitivity can give us some indication about the overall function of the nervous system. But then we need to drill down a whole lot more because it really is important to sort of shift that focus away from just looking at muscles and joints to understand, well, what's the difference between neurological pain versus somatic pain? And they can be very different, but they can also coexist together.
Definitely. And I think it's important, like if you've talked to any manual therapist who's been in this industry for a while, the ones that aren't up to scratch with their neuroanatomy knowledge or neurological assessment knowledge will still tell you, and we've been these practitioners at certain times, like, yeah, I still get results. Even though I don't know that well, I can still help people. So how important could it possibly be? Well, the answer to that question is you don't know what you don't know. And then when you do know what you're missing, it opens up your understanding to much broader and much deeper. When somebody walks through the door, like you're talking about, we've got somatic and we've got neurological pain. Somebody comes in and they've got an ankle sprain, for example, and you think, okay, well, the pain is coming from the damaged ligament, maybe joint capsule, torn muscle, whatever it might be. But there can also be irritation to nerves. There can be load on nerves. There can be decreased conductivity of nerves, which can then change motor firing patterns, which can change strength. And if somebody doesn't have the strength, then they can't rehabilitate properly. And so it's this cascade effect. It just kind of snowballs. And so unless you know, you don't know. All you're seeing is what you can see. And that's the problem, right? We want to give people a different lens to look with, give them the ability to look a little broader, a little deeper at these clinical presentations and see what they're missing. And the neurological assessment and treatment as well is such a critical part of that.
Yeah, 100%. We've got to also use that neurological assessment for our peace of mind and the patient's peace of mind as well, that we can rule out any serious pathology. It's a very useful cluster of clinical tests that we can use to say, okay, I'm pretty confident that there's no signs of serious pathology here. We can move forward with conservative treatment and avoid unnecessary imaging, surgical interventions, and injections. So differentiating spinal related pain, so radicular pain, somatic referred pain, and radiculopathy. So they're important to differentiate those terms because sometimes someone will say, well, I've got sciatica. What's that? And sciatica is now outdated terminology also. So the International Association for the Study of Pain recommends using the term spine-related leg pain instead of sciatica. And it should also encompass radicular pain, somatic referred pain, and radiculopathy. So I often ask a question to people, what's the difference between radiculopathy and radicular pain? And all of a sudden there's a bit of a blank look on the face. So when we look at radiculopathy, that's where there is, radiculopathy is not associated with pain. There's a loss of conductivity of that nerve, and it can be sensory or motor or both. Okay, whereas radicular pain is associated with pain and inflammation. Okay, so the conductivity of the nerve is still functioning normally. However, there's often positive signs, so levels of irritability. The nerve is functioning well. You can have a combination of the two. You can have a painful radiculopathy, but you can also have somatic referred pain, which often confuses people, particularly when they're talking about sciatica and, somatic referred pain can refer down the leg into even as low as the ankle. And, it does muddy the waters a little bit, because if you think about having an acute injury, right, let's say it's an acute disc injury, you could have chemical irritation that can sensitize the nerve root. You could have mechanical compression on that nerve root. All right, so that could impair conductivity. You've got the inflammatory component there with the upregulation of these sensitizing chemicals that can sensitize that spinal nerve. And then due to the injury, whether there's an annulus tear, disc bulge, sequestration, whatever it may be, there can be associated somatic referred pain from that. Okay, and when we think about that, then there can be this sort of abnormal or I guess different representation of symptoms compared to your typical dermatome or myotomal maps, your cutaneous nerve innervation. So there can be a little bit of variability there. So understanding the different factors and understanding the potential contributors on why that can be painful is really super important, because that can then help to direct treatment. But using a full neurological assessment, we can get a better understanding of what that is and educate our patients about the prognosis going forward.
Yeah, good. And you talked there about radicular pain and radiculopathy, and that's a nice sort of a key one to focus on, because I think most people with a rudimentary or basic knowledge of neurological symptoms, clinical features, would see somebody with the classic sciatica pain, which is the sharp shooting pain, lancinating pain down the back of the leg typically. And they go, well, that's a neurological problem. That's a nerve problem. Okay, it's probably a disc bulge. It's probably whatever, compressing that nerve. And once that's cleared up, problem's gone. But when you understand that you can have radiculopathy, which doesn't necessarily cause you pain presentation, and you could have, like I said, loss of conductivity, leading to altered motor function or altered sensation. People say, oh, look, I've got this kind of numb patch on the outside of my calf, or this numb patch on my hamstrings. Like, it doesn't really bother me. But, it's been there for a while now, and, it seems to be getting a little bit bigger, but, I'm not too bothered. Well, that's a potentially very serious pathology. That's a compression of a nerve, altering conductivity, altering sensation. And yes, they're not having pain, but is it any less important? Because over time, what happens to a nerve that's maybe being starved of oxygen or blood supply for a period of time is that nerve starts to die, starts to lose its function. And, going on long enough, that can be very, very difficult to resolve, if not completely impossible to resolve. And so we can very easily overlook a lot of these presentations clinically and dismiss them because they're not painful. Not all neurological symptoms result in nociception or pain, and therefore we have to understand that there's this whole gamut of different clinical presentations that we may not be focusing on, and therefore not realizing until it's too late, until we can't actually help that person, or until it's indicated for surgery or indicated for referral, indicated for whatever else. And so this idea of, again, coming back to not knowing what you don't know, it's potentially dangerous for the practitioner and the patient. And I think a lot of manual therapists might look at their undergraduate qualification, their diploma, advanced diploma, degree, whatever, and go, well, we didn't really cover the nervous system to a great degree or to an adequate degree, and therefore maybe this is not in my scope of practice. Maybe I don't need to worry about this. I can just refer off to the neurophysio, the neurologist, whoever it might be. But it's absolutely in your scope of practice. Every health practitioner can potentially learn about the nervous system more than they were taught in their undergraduate qualification. There's no limitation in the acquisition of knowledge. And then when it comes to assessment, well, of course, assessment techniques are within your scope of practice. They're potentially not dangerous if they're done well, and very effective in helping us gather data and clinically important information. So it's only outside your scope of practice if you choose for it not to be, or if you choose for it to be outside. And so if we want to dive in and get better at this stuff, there's information to be obtained, there's skills to be obtained. And even if you go, yes, I've determined that it's this neurological problem, I don't have the skill set to address it, at least you understand what it is. And that's good for the patient, because it means a longer period of time doesn't lapse before they can get the help they need. Maybe it's a handball to the appropriate practitioner, or maybe you go one step further and learn how to actually address these presentations as well. And it makes you an even better health practitioner in the process.
Yeah, and most of us are going to be first-line practitioners.
Yep.
A patient will hurt their back, hurt their neck, their shoulder, whatever, and they're going to present to you because you're the nearest clinic, or that they've heard that you're a good practitioner. So it really is up to you to be able to do that thorough assessment and not just apply a treatment without knowing what it is. So really spending that time going through a thorough assessment, and then you can triage them to the appropriate practitioner if you don't have the skills to be able to do it. But you'll be able to write a damn good referral letter as well, rather than just referring on saying signs and symptoms consistent with nerve pain. So that's the importance of a thorough neurological screen. And when we talk about that, we're talking about when we do a sensory assessment, looking at the difference between the function between the large fibers and the small fibers. So we can use light touch, we can use pinprick, we can use sharp dull, we can use hot cold, to get a better idea of is there a difference in function between those larger fibers versus the small fibers. We look at the conductivity of the motor nerves, the efferents, where we're looking at muscle power testing. We look at how well the sensory and motor pathway is functioning with our reflex testing. Again, that's assessing our proprioceptors sensory, and then that motor output, that reflexive output, and also using that to differentiate upper motor neuron disorders from lower motor neuron disorders, where we might see some abnormal signs. And that's an indicator that this person needs to be referred on because there's potentially a spinal cord compression or some form of upper motor neuron disorder, and they need the appropriate practitioner to be able to manage that. So we look at those as far as a neural screen, and then when that sort of tells us about the conductivity of the nervous system, the sensitivity of the nervous system. But then we've got to go and look at mechanosensitivity. So I often also hear things that I did a slump test and a straight leg raise, and they were fine, or they were positive, so they had this condition. Well, all as that tells you is that they are sensitive, that nerve is mechanosensitive. It doesn't tell us about the conductivity of the nervous system, or of that particular nerve that we're trying to assess. So using nerve palpation is one good indicator, and none of these tests in isolation are really useful, but using nerve palpation can tell us if that nerve is mechanosensitivity, if it reproduces their familiar symptoms. And then using neurodynamic tests, once again, can show us if that nerve is mechanosensitive and the level of irritability and sensitivity based on the amount of provocation that we put it under, or the amount of neural load. So they are fantastic tests, and clustering that all together gives us a good idea of the health of the nervous system, the level of irritability, and the sensitivity, which can help us to direct our treatment.
No, I 100% agree. And I think that understanding that the neurodynamic tests in particular are probably one of the most underrated tests that we were ever shown, at school, if we were lucky enough to be shown them. Most people would know them by the tension test name, upper limb tension tests, 1, 2, 3, and so on. But now we know there's a much broader range of tension tests or neurodynamic tests available to us. And they very easily and very quickly become treatment tools as well. A slight adaptation to the way that they're applied as an assessment technique, you can start to use them to decrease mechanosensitivity. One of the best things you can do for a nerve that is mechanosensitive is to slide and glide it through the surrounding tissues using these tests, using these movements. One of the unfortunate things with nerves is they don't necessarily have their own internal lymphatic drainage system. And so you talk about some of those neuroinflammatory chemicals before, and the things that can build up inside an inflamed nerve. Mechanically sliding them through tissues can essentially kind of milk that nerve and remove a lot of the waste products. It essentially providing its own kind of lymphatic drainage technique to the nerve as you're gliding and sliding it. And very quickly, and we're talking in the space of a few minutes, you can dramatically decrease somebody's mechanosensitivity, their sensitive nerves, their level of pain, just with these techniques, and dramatically improve the quality of somebody's life with some very basic techniques. So we see people with this debilitating nerve pain, the sciatic type nerve pain, the upper limb kind of median nerve impingement, or whatever it might be. And we look at that and go, oh, you poor thing, look, that's going to be it's going to have a real negative effect on your life. You're going to have to take some time to work through this, see the appropriate professionals and specialists. But we can, like I said, dramatically decrease their symptoms in a number of minutes and then give them those movements, those same movements that we do clinically, to do at home so that they can maintain that reduction in mechanosensitivity while we're then working on reducing that mechanical compression or whatever wherever the load might be coming from that's compressing, irritating, and making that nerve mechanosensitive.
Yeah. So the perception of that as well, when a patient comes in with nerve pain, they're often in a lot of fear. They're very guarded. They're very apprehensive of movement. Now, there's research to show that, comparing splinting versus neurodynamics, that neurodynamics have a greater benefit than splinting. And we think about the mechanism behind that. Well, nerves are very bloodthirsty.
Yeah.
Now, blood delivers oxygen to the nerve, which provides healthy function to allow for appropriate action potentials and, conductivity of that nerve. So if we starve the nerve of oxygen, that can lead to decreased function, decreased conductivity. It's sort of like when you sleep on your arm in a funny position and you wake up with a dead arm, right? You move that arm around, you get it moving, you squeeze your hand a few times, and then function starts to return, right? It's because we're getting blood back through that nerve. So you can imagine after long-term compression that there's that nerve is being starved of oxygen. There's not that lymphatic pumping mechanism that you spoke about, so we get venous backflow, and this is where the sensory changes or the loss of conductivity can occur and spread along the length of the nerve. So
all right, so if it sounds like this is something you want to learn more about, if you think you'd like to fill this gap in your knowledge base, though, we have our complete neuro assessment and treatment course that we run in a number of locations around the country. Tell us about where they are and when they are.
So it's a 2-day course. The next one is coming up in Melbourne on the 1st and 2nd of September 2023. Then we go to Perth on the 2nd and 3rd of December 2023. And then if you're looking ahead to next year and you're in Queensland, the 27th and 28th of April 2024.
All right, that sounds good. If you want to check us out, you can hit the website, advancedclinicaled.com. Those courses and all our other courses are there. We hope to see you soon.
That can lead to serious dysfunction over a long period of time. But when a patient's in a lot of pain, particularly when this occurs in acute nerve injuries, they'll have that associated muscle guarding and spasm and worry that I don't want to move it because it's going to make it worse. So with neurodynamic mobilization, we can show them how to move in a comfortable way to decrease their level of threat and fear, but also can reduce their symptoms. So we can see how this can be a step from passive interventions through to active interventions as that little step in between. Let's get you more comfortable with movement. Let's get you doing this regularly. Even when these symptoms are quite irritable, let's get you to start to move that limb, move that arm to decrease your overall sensitivity. Get this rush of blood flow into the nerve and good oxygen, good nutrients, so we can improve the health of the nerve and decrease the amount of these sensitizing neuropeptides and other sensitizing chemicals.
So it's important to look at, these. We've been talking about the peripheral nervous system primarily here, but essentially any pain presentation, any time that a patient presents to us with pain, which is pretty much every time they come to us, there has to be a neurological component to it. If we are experiencing something from a sensory exposure, like put that a different way, if you are receiving sensory input to the central nervous system, you are implicating the nervous system. Try to avoid having an implicated nervous system with an arthritic knee, where you think, well, that's just joint surfaces and bones. Yeah, but you're getting pain as a result. And so if we have pain that goes on for long enough and we have this consistent nociceptive bombardment of the central nervous system, we can develop something called central sensitization. We've been talking peripheral, but there can be structural and functional changes at the central nervous system as well, like the spinal cord. And so it might be something as simple as an old arthritic knee or a fibrotic hamstring that's, old football injuries, or a trigger point in your deltoid. Anything that causes constant nociceptive input to the central nervous system can potentially, if there's the right compounding and contributing factors, can potentially result in central changes in the central nervous system. And then that becomes this bit of a chase the symptom story, where the patient reports to you and they say, I've been to see 15 different therapists, I get short-term relief, but I don't really resolve the issue. Well, this is the perfect example of why we have to understand neurological assessment, because if all you're doing is chasing mechanical type symptoms, pain symptoms, then you could be very easily missing the central driver of that, which may be a central sensitization, a peripheral sensitization, or potentially both. Those two things you can't test with an empty can test. You can't test with a range of motion assessment or postural assessment. Those things miss it completely. We have to understand the nervous system to be able to, first of all, identify those things if we've got any hope of addressing them.
Yeah, and so that's when we look at these pains that are disproportionate to the I guess the amount of stimulus applied.
Yep.
And it's sort of an unremitting pain. It's always there. Nothing aggravates it or eases it. It's just persistent. So these are those ones that are typically in those patients that have had their pain for several years. Like you said, they haven't been able to find a solution, and they're often looking for something that makes it go away. But these things can be slow. But also, I think we understand some of the mechanisms behind that and why that changes. As you said, any input to the nervous system, that is input, right? That is sensation, but the perception of that happens in the brain, and the interpretation of that is where the pain experience comes from. And this is based on expectations, previous experiences, and emotional factors, environment, a number of other things. So someone that's in a heightened level of sensitivity and irritability, they may have a whole lot of other things going on that can amplify those pain messages or those nociceptive inputs. So we've got to understand that and address the person as a whole. Nerve pain can be highly debilitating. It can be really, really uncomfortable. And obviously the interpretation of that I can't do anything, it's only going to get worse. That can amplify all these messages. So if we think about what mechanisms are also occurring peripherally, and we've got to understand those things that are occurring centrally as well. So you could have injury or irritation to a nerve where we have messages that are sent from the dorsal root ganglion. Now, this is a collection of cell bodies that essentially regulates the nervous system, the peripheral nervous system. So let's say that we have a peripheral nerve entrapment in the tarsal tunnel. So someone's presenting with plantar heel pain, plantar surface of the foot pain that's driven by compression or entrapment of the tibial nerve. Now, what happens from that dorsal root ganglion? It will send antidromic messages, so increase in these sensitizing neurochemicals down the opposite direction of that sensory nerve to the location of compression or irritation or sensitization. So that will sort of upregulate those action potentials that are being sent from the periphery, and that's peripheral sensitization. So also what's happening at that dorsal root ganglion, it's sending messages orthodromically, which means in the appropriate direction towards the dorsal root ganglion. So that also sends similar neuropeptides and neurochemicals to that dorsal root ganglion that can upregulate or lead to a pro-excitatory state, the dorsal horn. Therefore, any sensory input that arrives at the dorsal horn is very excitatory, and there may also be a loss of descending inhibition from the brain. So the more that happens, the more that input to the central nervous system happens, the more efficient those synapses become, the more efficient that neural pathway becomes. So it's like if you practice something, you get really good at it, right? It's the same with pain. The more that input occurs, the more awareness there is in the central nervous system, the more interpretation that's a dangerous, harmful stimulus, and that can lead to changes that are occurring in the brain. And this is essentially long-term potentiation that occurs. So that experience of any sensory input, it could be light touch, light movement, that could be perceived as a dangerous input. So when we look at our reasoning behind why we do mobilizations and why we do manual therapy and neurodynamics, it's essentially showing the person that this movement is okay, it's safe, it's comfortable, while we're having some other effects. We're showing them that we've got to progressively get you moving into these positions to decrease your level of sensitivity, decrease your level of fear, and promote long-term recovery.
Definitely. And this is the classic clinical example of when the patient has an busted old ankle injury they had from years ago, when they're in the army or playing soccer or whatever the story might be, and they come in and they go, yeah, it happened 20 years ago and I still get ankle pain as a result. And they go off and have the scans and imaging done and do all the orthopedic testing and range of motion testing, and they come back and say everything looks perfectly normal, but they're still experiencing pain. And they'll, because of that, avoid certain movements and avoid certain activities. And nobody can seem to explain to them why they're getting pain anymore. And of course, at some point, someone comes along and says, oh, the pain's just in your head. Well, that's not entirely true, is it? If we understand what you're just talking about, we understand that the pain can actually be derived from, or the pain experience can be derived from something happening at the spinal cord, at the dorsal horn. And so until we can understand that, we get stuck in this kind of scenario where we can't really articulate this to our patients effectively. And all we can say to them is, you're experiencing pain, but there's nothing wrong with your ankle. And they can't join the dots. But if we can understand what the implications are here, what the mechanisms are that are still creating this pain experience or this uncomfortable experience for the patient, then we can actually be empowered enough to be able to do something about it. We can say, right, okay, I know what the source of this is for you. It's actually not your ankle anymore. It's here. And here are some real strategies that we can use to decrease that sensitivity, decrease that pain experience for you. So you can move away from this and move towards function. But if we just look at things from a mechanical perspective, a tissue-based perspective, we completely miss this opportunity to not only understand it, but be able to do something about it. And this is, I guess, what we'll come to today's conversation, which is, do you know your neuro? Well, if you don't, you really tend to limit yourself, I think, and potentially limiting the outcomes for your patients. So this today's not to be designed as a lecture at you, as like, you really need to go and do this, you need to figure it out, but more to sort of just make you aware that you might be missing some stuff. I'm guilty, Bo, you probably put your hand up as well and say we've both been guilty of missing this stuff in the past. Patients will come and see us, and we do our best job with what we know. Of course, we all do, right? I know how to do this stuff well, I'll do that. And hopefully that gets me there. But when you know a little bit more, you can do a little bit more, and you can help a little bit more. And that's really what we're focusing on here.
Yeah, and I had some really great experiences teaching the podiatry neuro assessment treatment course on the weekend. And a really valuable part of it was using the complete anatomy apps and showing them where these peripheral nerves go. They pass under muscles, over muscles, around bony prominences, piercing through different levels of fascia. So understanding that mechanical interface is really important. But so many of them had these penny drop moments where they go, I didn't realize that was the location of that nerve. And that potentially explains a lot. I need to go and look at that in these patients. And knowing that mechanical interface is super important, because then you can, with your neurodynamic mobilization, you can direct that more towards that area. With your manual therapy treatment, it can be a little bit more targeted towards that particular region. It's like you look at someone, back to mechanisms and locations of symptoms. You mentioned about the hamstring injuries before. Well, knowing that sciatic nerve passes just lateral to the ischial tuberosity, and we've got the proximal hamstring tendon there, that can sensitize the sciatic nerve. Different areas in lower down, like the common fibular nerve as it wraps around the neck of the fibula. That's a common site of entrapment and sensitization and irritation that often is sort of labeled as a runner's knee or an ITB friction syndrome. Well, what if it's not? What if there's a neurological component that's leading to the persistence of these symptoms? What about in runners that present with persistent calf pain or that twang that they experience all of the time? Well, what if it's the sural nerve as it pierces through that crural fascia? And we have a look at these interfaces and think, okay, well, yeah, that makes sense. That's close to that musculotendinous junction. We've got the two communicating branches of the sural nerve. And, so following that nerve pathway, I think maybe this could be involved in their presentation. I know that when I worked with the AFL, I was always, when someone was presenting with hamstring strains and calf strains, that a part of their rehab was to do some neurodynamics. So I think that's important to understand that when someone is going through these rehab plans and even just a pain presentation, we've got to assess it. Is this a contributor? And if so, how big or small is that contributing factor to a neurological pain versus just nociceptive pain?
Yeah, perfect. And look, just to wrap this up, I think another thing to think about too is the fact that we're looking at clinical presentations from an exercise strength-based perspective. A lot of the time we'll see, I'll hear patients who come and say, I went to see such and such and they gave me glute exercises or activation exercises and I've been doing them, but I don't really feel like they're getting there. I don't really feel like I'm getting any stronger. It's not getting any easier. What are we missing? And it may be that we're missing the fact that, yes, we might need to strengthen that muscle, activate that muscle more effectively. But what if you can't because it's neurologically compromised? What if the nerves, the motor nerves that supply that muscle are being compressed somewhere up the chain? They've lost conductivity, and therefore you're trying to drive an 8-cylinder car on 2.5 cylinders. It's just not firing. And so we can be strengthening and trying to fire up those muscles and loading them and loading them and loading them and end up in this frustrating cycle of I don't really feel like I'm progressing. I think we've all seen patients that are like, I'm doing the work, but I don't seem to be getting any better. It may be that we've missed something. We may have missed the fact that there is a proximal nerve compression happening in the deep gluteal region that's affecting our ability to fire up that nerve that supplies the muscle. So that loss of conductivity affects the ability to get the mechanical or motor outcome that we're chasing. And all you're doing is testing muscle function without realizing that there's a neurological deficit. And this is the problem, right? Again, what it comes back to, we don't know what we don't know. We're not seeing what we can't see because we don't have the right lens on to be able to look at it.
Yeah, I agree with that for sure. There's a lot to it when we look at clinical presentations, and it'll rarely fit the textbook picture when we look at nerve pain. And there's a number of research articles to demonstrate that these patterns often significantly vary person to person and segment to segment. So it's important to have a good grasp of all of what it could be, what it potentially should be, and then the differentiation between the two.
Very good. Yeah, nice. All right. Well, hopefully everyone who's been listening has been able to pull out 2 or 3 little tidbits from this that's helped them realize that maybe they're not seeing the full picture and there are opportunities to be able to get that picture clear in our minds so that we can help more people and get better outcomes. So thanks for listening, everyone. Hope you enjoyed that.